Okay, and I lost the presentation on your end.
Yeah, I'm just going to start recording it first and I'll swing it back over.
Oh, okay. So I'll just introduce myself. My name is Michelle Radloff. I am the clinical coordinator here at United Training Center. I'm the one that calls around to all the services and bugs them and tries to get our students in to do their ride time. My understanding is that you guys have precepted students from other programs. Is that correct?
Yes. Yes.
Yes. Okay. So the good thing is that the KHEP requirements are pretty much the same for everybody. All of the regulations are pretty much the same. Different states' protocols are a little bit different, but as far as what we need to teach the students and how we train our preceptors or what we have to train our preceptors on is pretty much the same thing. How we meet some of the standards is sometimes a little bit different. And with United, we're a little bit different than, say, a college-based program. And if you want to go to the next slide, in that we're a consortium, we're not based out of a college. And as a consortium, we're owned by two hospitals, Central Maine Medical Center and St. Mary's Regional Health Center here in Lewiston, as well as United Ambulance Service, which is our parent company. And I think one of the things that does for us is we are very close to our customers that are going to be hiring our graduates. They are our board of directors. They are able to have input into our curriculum and into how our program runs, so that what we're putting out at the other end for them to hire for providers is what they're looking for. And I think that's a really great thing. The other part of that is that we have close relationships with all of our sites that take our students, and we really want their feedback on how our students are doing. Is what we're giving them for skills and knowledge in the classroom able to be brought into the field and give them what they need to be competent providers out in the field? And is there anything that we can do while they're still in school to help improve that for them? So any feedback you guys have for us, my cell phone is in this presentation and everyone has access to that. You can give me a call, let me know. If it's in general about what the kids are learning, or what the students are learning in class, or if it's about a specific student, either way, our door is always open. Our paramedic program director is Susan Urich. Her contact information is in here as well. And our AEMT program coordinator is Michelle Mullen. And although her contact information is not directly in here, she can be reached at the same number you reach me at. I'm very glad to be working in New Hampshire. We are getting more and more students in New Hampshire, and I was born and raised there. I raised my children there over in Tufton Borough. So I'm very familiar with the area, and I'm very glad that we're getting some students from over that direction. Seems to be a trend. We're getting more and more in that area. So we can go to the next slide. Again, this is our goal of United Training Center. We want to prepare competent entry-level paramedics and AEMTs. There's 3 domains of learning that KHEP really stresses with us, that we need to not only be doing these 3 domains of learning, we also need to be evaluating our students in all 3 of these domains. The first one is the cognitive, which is their knowledge, the information that they're getting in their didactic classroom training, as well as their psychomotor skills, which is their lab training and doing the hands-on with the mannequins and practicing on pretend patients in the lab environment. And then the affective domain, which is the newest one for KHEP, but it's been around for a few years now. And that is really, how are they interacting with fellow providers, with the patients, with the providers that they're meeting in the hospital. How are they doing their handoffs? Are they part of the team? All of that kind of stuff that is a huge part of being a provider in the field of EMS. So what we ask for from preceptors is that when I go through the paperwork, there's a section that really rates the student on how they're doing in that affective domain. And then there's a couple of places on the back of the form for you to kind of document how are they doing with their hands-on skills and how are they doing with their knowledge base. Do they have the knowledge? Do they understand the medications? Do they understand, you know, the disease processes that they're encountering out in the field, that kind of thing. So there's places on the form for you to kind of comment on all three of those domains. We can go to the next one. The next slide. Oh, there we go. And again, as a preceptor, you are a huge part of the education that the students get. And we want to partner with you to make sure that that's a good experience for you and for the student. So go to the next one. This is harder doing it with somebody else doing the slides. Another difference for our program versus a college-based program is a lot of the people that come to our program are people that are already working in the field. So they're, you know, basics that are going to AEMT, or sometimes even basics going to paramedic, or advanced going to paramedic. They've been working in the field. Sometimes they're a little bit older, although our demographic is actually getting younger here. We have some fairly young students in our paramedic program right now, but they also have full-time jobs. They work in the industry. They have families. They come to the program sometimes for different reasons than the college-based students do. Some of the college-based students are heading into EMS, and that's what they want to make their career of. But some of them are using it as a in-between as they go on to nursing or medical school or something like that. So with that comes a little bit of challenge for some of our students, being able to schedule in all the time that they need to for their clinicals, their classroom time, their homework, and all of that stuff, because in their families. So we really stress with them about being responsible. If by chance they have to cancel a shift, that they're contacting you first, letting you know that they're not going to be able to be there, and then letting me know that they were not able to be there. We do evaluate for excessive absences in clinicals, and if you're having any problems with any of the students, definitely reach out to me and we can have a conversation with that student. Most of our students, though, because they're either at least partially or fully paying for their courses themselves, they're very invested in being here and getting the experience and following through. So we don't have a lot of problems with it, but occasionally we do have, you know, students that will sign up for shifts and then either not show up or cancel multiple shifts in a row, or frequently cancel shifts. So I definitely need to know about that too. Again, we try to be a little bit lenient with our students because they have all that other stuff going on as well. And again, coming in from being in the field and working in the field, they come in with some experience. Sometimes that's good because they know the industry, they know how the ambulances work, they know all of that stuff. But the other side of that is they could have some bad habits too that they need to work through as they move up in their licensure level. We can go ahead to the next slide. Students that come into our program, especially are more hands-on, tend to be more hands-on learners. Everyone comes to the table with a little bit different learning style, and sometimes that also means they fit better with one preceptor or another. So during our students' initial phase, what we call their field team member time, we encourage them to try to ride with a couple of different preceptors, and really, one, to see how different preceptors run the back of an ambulance, run the environment of care, the scene management, all of that, just so that they can get that experience. But also to see who might fit best for them when they're going on to their capstone, which is their team lead time. Once they get to their capstone, we do try to ask that they stay with one or two preceptors during that time, just so that there can be some continuity of evaluation and making sure that as they go through that capstone and that team lead time, that they are ready once they get done to be that entry-level provider out in the field. So again, that's kind of how we do it in ours. I know there are some programs that say they have to be with the same person the entire time. or with the same service the entire time, we tend to let them during their team member time try out a few different places or a few different preceptors to see what fits for them and kind of what their style might be. So we can go on to the next one.
What time on Tuesday?
Again, this is our contact information. So that is myself, Michelle Radloff. Susan Urick is our program director for United Training Center. Dennis Russell is our dean. He is actually part-time now. He was full-time with us. He is down in Massachusetts now, working for Cataldo Ambulance, but he is still our dean, works part-time. If you have any problems that you'd like to discuss with him, he is always open. Okay. Again, this is kind of, you guys have been preceptors before, so I'm sure you understand. Try to make that field time a place where the student is progressively getting more and more experience and progressively taking more and more responsibility for the calls, and really having it be a place where they have that backup and that they can feel comfortable and feel supported moving forward and trying those harder skills and taking the lead on those calls. But be honest and direct with the feedback with them. Let them know what they need to work on. One of the things that, as an educational institution, although we're owned by an ambulance, it gets confusing. We're not held by the same rules that the ambulance is. But we do have our own rules as an education facility. So one of those rules that we have to follow is FERPA, which is the federal, it's kind of the HIPAA of education. And so if there is a student that's struggling or that has something that they need to work on or something that you need to address with them, they do have the right to have that done in private. So you know, kind of, if you have to critique them, do that in private if at all possible. Positive feedback is always welcome, and you can do that anywhere. But if you do have to provide them any kind of critiquing, try to do that in private to follow the FERPA rules. If some people have a hard time with that, giving you know, kind of that constructive feedback to students. And I'm always available if you really need to meet with a student, let me know, and you want somebody else to be there from the school, let me know. If it's something big, I can even make arrangements for us to all meet in person when they're doing their next ride time. I can come over, or if we can do it by Zoom or by phone, that would work too. But I am available to come out if it's something that we really need to work through, if they're really struggling with something specific. Let me know and we can work that out. Okay. Next slide. Okay, I think that's pretty much, that's the same thing we just talked about. Go to the next slide. And again, kind of giving them that place after each of the calls to really talk through the call itself, what went well, what didn't go well. A lot of times we do this anyway in the back of the ambulance on the way back. We kind of, as a team, we talk through how did the call go, what could we have done better, including them in on that that discussion, and kind of going out of our way to have those discussions with students is really important. And then helping them plan how are they going to improve that for the next call. What are they going to do differently on the next call? We can go to the next one. This is again about that FERPA. You can praise in public, critique in private, and maintain the confidentiality. Use us in that process if you need to you know, help facilitate that feedback to the student. Next. So when a problem is identified, sometimes for us, one of the good things is that we do our clinicals with our students throughout their program. So how our class is structured is half of the day the students are in didactic training. So they're in the classroom, they're getting lectures on the topics for that week. The other half of the day, they're actually in lab. And we break the class into 2 groups and they switch at noon. So half of the day is in the didactic, half of the day is in lab doing hands-on training and scenarios. And it happens at the same time they're doing clinicals. So they'll have a certain number of hours that they have to do each semester, and in different environments. So they have hospital time, they have field time. And so if you identify a knowledge gap or a psychomotor issue, maybe it's just the physical skill that they're having trouble with, we have a captive audience with them when they're in class. And I'm sure if your student is having a little difficulty with it, there are other students that are as well. So if you reach out to me and let me know, hey, they're struggling with this concept or they're struggling with this hands-on skill, we can actually wrap that into some of the lab time that they have the next week, and we can re-practice that and we can have conversations about that, or we can add a review piece into their didactic time for the next class. So that feedback loop is really good for us because we can reinforce those skills and those topics when they're in class the next time. If it's an affective issue, if it's something as far as them being part of the team or how they're interacting with other providers or something along those lines, that is something that we can also work on with them when they're here in class, if that's something that you would like us to do. So don't feel bad about reaching out for that type of thing as well. Okay, we can go to the next one. So for our programs, there are 3 phases of ride time. The first phase is observation. That one applies to the basic to paramedic program. So that these are students that come to us as basic EMTs. They have to have at least 1 year of experience as a basic. We'd like them to have 2, but they need to have at least 1 year of experience as a basic EMT. I don't know about in New Hampshire, but I know here in Maine, a lot of times if you're a basic EMT, you do get some scene time with the patients, but for the most part, you're doing a lot of driving, especially in the services that are paramedic level and have paramedics on every ambulance. So they don't get a lot of time in the back of the ambulance. They don't really get to see once the patient is in the ambulance, how does that paramedic run the back of the ambulance? So we like to give them at least 1 shift of just being able to observe what's going on in the back. How is the paramedic preceptor that I'm with? How do they run the back? How do they interact with the patient? That kind of thing. It also gives them a chance, if they're riding somewhere other than where they work, it gives them a chance to figure out where things are in the ambulance. So that's that observation time. They then quickly move on to team member time. Team member time is where they're going to be practicing their skills. They're going to be working up to taking more and more responsibility for the calls. This is pretty much where our AEMT our AEMT students spend a lot of their clinical time. They will be leading some calls that are at the AEMT level, but for the most part, they do a lot of the team member stuff. And then for our paramedic program, there is an official team lead portion of the program, which is 144 hours. It's in their final semester. So for the AEMTs to paramedics, it's their 3rd semester. For the basics to paramedics, it's their 4th semester. They do 144 hours, and they have to have a minimum of 30 team leads if they're already an AEMT and 50 team leads if they're a basic that's going to a paramedic. Okay, so that's kind of how they flow through the phases of their ride time. Is there any questions on that part? A lot of times during the team member time, depending on the semester that they're in their team member ride time on, will depend on what skills they can do. And the student should be able to tell you what skills they've been tested out on. What I can do is also send over to Kevin a list of the skills that they learn each semester. By the 2nd semester, the AEMT to medic students are all able to do all paramedic level skills by the 2nd semester. The basic to paramedic students, it is later in second semester, beginning of third semester, they should be tested out on all of their paramedic level skills and be able to do them in the field. So again, the student should know what they've been tested on and what they're able to do in the field. We can go to the next slide if there are any questions.
I got a question, Dave.
Yeah.
When they come, are they going to have their ACLS, PALS? What else are they going to have for certifications?
So they will not necessarily, when they start their ride time, they will not necessarily have those certifications. They do get those certifications as part of the program and have them before they finish. And the ones that they get are PALS, ACLS, PHTLS, and in Maine, we have what's called PIFT training for PIFT transfers. So they get those 4 certifications during the program. They do have their BLS before they ever start the program. But as a student, but as a student, they can still do all of those skills that they've been tested out for up to that point. So for right now in our AEMT program, they're testing out their final for their second semester is next week. And so they do have their ACLS, their PALS, and their PHTLS. The basic to paramedic, they're in their second semester. They have done their PHTLS and their ACLS. They have not done their PALS yet. Does that help?
Yes, thank you.
Okay. And so this slide is a little bit older. These changes have actually been in play for a couple of years now. We do have a brand new change that is just happening this year. We used to have 2 reports that we had to complete in order to have the student have a completed portfolio for the program that allows them to graduate. One was called the Appendix G. It's now the student minimum competency, and it was a whole grid of ages, presentations, skills that they needed to do in order to finish the program. And then there was also a graduation report, which was some of the same things that were in the Appendix G and a bunch of other stuff. They're now bringing that all into one report, which is the student minimum competency. For our students, we require that they have that report completely filled out and completely green before they can start their capstone. So they will have had all of their contacts for age ranges, presentations, all their basic skills that they need. They will have gotten before they go into their capstone, so that they don't have to worry in their capstone about meeting some of those other requirements anymore. The only thing they have to make sure that they do is meet their team leads. They have a lot of hospital time, so they do a lot of emergency room time, and a lot of times that's where they get the majority of those contacts to fill that grid in, just because they're seeing more patients faster. So we can go to the next slide. Again, these are a lot of those mandatory skills and assessments that I just talked about that were part of the Appendix G and the graduation report. And again, they'll get those prior to starting their team leads. So we can move on to the next one. Complaints, again, just kind of that same grid. Those are the things that they need to have. Next slide. Mandatory skills on live patients. Next slide. I see Chris down there. He's probably having flashbacks and PTSD from this. Again, so the UTC programs, these are the 2 paramedic programs, the AEMT to paramedic and the EMT to paramedic. And we also have an AEMT program. We do 1 of each of the paramedic classes per year, and we do a minimum of 2 of the AEMT classes a year, but we're also doing remote AEMT classes, which are hybrid. They do a lot of their didactic stuff online, and then they meet once a week in lab to do their labs. And we've been doing anywhere from 2 to 4 of those a year. So we have quite a few students coming through here. I right this moment have 80 students doing clinicals. So we can go to the next slide. And that is their hours. We can kind of skip over that because that is a lot of their hospital time and everything. And again, we want students that kind of do the critical thinking piece. So that debriefing that we talked about after the calls is a great time for them to start talking about what the differential diagnoses were they had for the patient that they're seeing, and why they came up with those, and then what their final impressions of the patient are, and what they did for interventions and why. So next slide. So this is the paperwork that students will use during their team member time. So what this is the page at the top on the left-hand side. That's the log that they fill out. They need to know the age and the gender of the patient, as well as the primary impressions and the complaints. Then they fill in whatever interventions that they did on the patient, and then whoever precepted them for that particular patient. At the top of the page, they're going to put in who their primary preceptor is, and that's the person that's going to sign off on the form for them. Down the right-hand corner, that's the back of the log form that I talked about that has the grading section on it. So it's a place for the preceptor to put things that the student did really well at, things that the student needs to work on a little bit, and then that affective rubric about how were they as part of the team, how did they have, how was their time management on scene, how is their self-confidence, all of those affective areas that we need to evaluate the students on. Both the student and the preceptor need to sign the back of that. And then what the student will do is they have to enter those patients into FISDAP as part of their portfolio. They enter all of the skills that they did on that student, on that patient, and then they upload a copy of this form to that shift as well. Okay, and again, that's for the observer and the team member phase. You can go to the next slide. Okay, for the paramedics, as they go into their capstone experience, we talked about the fact that EMT to medic need 50 team leads, AEMT to medics require 30 team leads in that same 144 hours. Any call, pretty much any call that they do that's a 911 call can potentially count as a team lead, as long as they are doing a full assessment of the patient, as long as they're getting at least one set of vitals, and that the student is doing the majority of the care and education of the patient. So even if the patient signs off, as long as that student is doing the sign-off checklist that we have to do with all of our patients, giving them the education and what to do and send symptoms to look for and all of that, as long as they're doing that, it can count as a team lead. Do you guys do transfers, correct?
Yes, we do.
Okay, so transfers, a student can have as up to 5 transfers as part of their team lead portfolio. The difference with the transfers is they have to be an ALS level transfer. They can't be a BLS transfer, like back to a nursing home or anything like that. It has to be an ALS level transfer with either meds running or cardiac monitoring or something like that. And again, they can only have 5 transfers as part of their 30 or 50. Again, the goal is that at this point in their program, they are running the call with some support from their preceptor. If they have to have significant prompting, and what we call significant prompting is that the student is going to give a medication that might harm the patient, or they're about to give a wrong dose of a medication and the preceptor has to stop them. If they go to move a trauma patient without putting a C-collar on them, or at least ruling out the C-spine, and the preceptor has to stop them, those are pretty major things. if a student is having a conversation with a preceptor about their potential differential diagnoses or what they're seeing on a 12 lead, those are conversations we normally have with our partners. So we don't consider that major prompting. But again, just part of the care. It's your call whether you think it is a significant prompt for that student or not. If it is, if you had to do a significant prompt on a team lead experience, you need to make sure that you write it on the form so that I can see that you had to do that. The goal is that by the last 20 of their team leads, they are no longer getting significant prompting. So those last 20, before they become a paramedic on their own, they're able to pretty much run their calls without a lot of significant prompting. We do allow 1 to 2, depending on what the prompting is, without them having to do extra team leads at the end. The preceptor has to be with the student the entire time. The student shouldn't be alone with the patient at any time during the call. The other thing that we're running into more and more now is we have students riding where they work, and that causes a little bit different dynamic that we have to address as a school. And that is that when the student is riding during clinical time at the place that they work, they have to be identifying themselves as a student. They have to be acting in the capacity of a student. They can't be acting in the capacity of as an employee. They can't go to the call, be a student and treat the patient for part of the call and do firefighting or drive the ambulance the other part of the call. The reason is that one, just for liability purposes, whose liability insurance is covering the student at that time? Is it their liability insurance as an employee of your organization, or is it the insurance that we cover on them, that we carry on them as a student? But also it's about acting within their scope of practice. So if they're acting as a student, they have to really be acting as a student so that we know they're not practicing outside their scope of practice. So if they're on a regular shift and they're working for you and they only have a basic EMT license, when they're working, they can only do basic EMT skills. When they're riding as a student, they can work up to the paramedic level with that preceptor with them. Any questions on that? Okay, we can go to the next slide. And I apologize, we're running over a couple minutes. So again, this is the team leader definition. You guys can kind of read that on your own, but the big thing is that the patient is doing the assessment, they're formulating the treatment plan for the patient. There's not a lot of prompting needed from the preceptor. And it doesn't mean that they have to do all of the skills. And some of the times we have a hard time with the students as they're moving from team member to team lead time to remember that part of being a team leader is that resource management and directing the rest of your team and what you need from them. So that's something that a lot of times they need some support from their preceptors on, is how do I do that? How do I go from practicing my skills because I needed all the practice for my skills to actually being that team leader that is directing other people to do those skills. Okay, next slide. And again, that's just the code. You've been preceptors before, so this is the standard from the accreditation organization on what it means to be a team lead. We can go to the next slide. And I already went over this. This is just what counts as a team lead. We can go to the next slide. And again, this is talking about the fact that 18 of the last 20 leads have to be without prompting. So we talked through all of this already. Next slide. So this is the paperwork, and so the paperwork for the team leads, the capstone is different than the paperwork that they do during their team member time, where they're just logging their patients and the skills they did. So this first page, the student will fill out themselves. This is where they're rating themselves on how they did in these different areas, what their preceptor had to, maybe prompt them on, or what questions they had during the call that they needed some support from their preceptor on. And then down at the bottom, they're talking through their strategy for next time they have a similar call. What are they going to do differently? If we go to the next page. On the back, this is the section for the preceptor to fill out with the student. So the top part is things that the student might need to work on. If, maybe some of the stuff that the student wrote on the front, maybe some other things that the preceptor observed. What is the plan or maybe a strategy for improving that during the next call? The next little section down is anything that they did really well. We love to hear good comments about the students, what they're doing well. How they interacted with the team and other providers during that call. All that good stuff can go into that section. And then the bottom half is about their documentation. So when they get to the team lead portion of the program, what we're asking the students to do is pretend that they're on a shift. When you see a patient, we want them to do their documentation in FISDAP just like they would if it was a real call for them out of service. So they're going to go into FISDAP and they're going to enter all of their patient information and do their narrative, and they're supposed to be reviewing that with their preceptor. And really what we're asking for the preceptors to do is really look at it from the eyes of your QA. Is this something that would hold up to an ALS level run report through your QA process? And is there anything that the student needs to work on to make sure that their run reports are meeting those expectations? So again, that's that bottom section. Both the student and the preceptor sign off on that, and the student will upload. There's one of these for every single patient that they see during their team leads, and they will upload that to the shift once they're done so that I can see how they're doing and if there's anything they need to work on. Next page. So there is one other sheet that the student is going to have with them for their team leads, and that is every day they'll just have one of the rubrics for their affective domain, just like is on the logs that they use for their team member time, that they'll just have you fill out and sign, and that's giving them credit for the hours that they were there and giving us that affective assessment on how they did that on that shift. So they'll have one of those for each shift and then one of the team lead sheets for each patient that they see that day. Any questions? If not, thank you guys very much. I apologize for the little bit of a rough start with the teams. This was my first Teams presentation, so thank you very much. And I really look forward to working with you over in New Hampshire. Hi.
Sorry.
Hi, Brandy.